Hi everyone, my name is Tanasia Street. I'm going to be presenting on a community-acquired pneumonia, and I am an FNP student at St. Joe's College in NP 612, Family Theory of the Young and Middle Adult. Community-acquired pneumonia is an acute infection of the lung parenchyma in patients who are not hospitalized in long-term care, have close affiliation with healthcare exposure, or have been recently discharged from the hospital. It carries a huge global burden with millions of cases and significant morbidity and mortality. And it ranges from mild to severe with complications such as sepsis, ARDS, and even death possible. CAP occurs when pathogenic bacteria or viruses invade the lower airway and alveoli of the lung, and this causes a big inflammatory response, causes edema, exudates, and lung consolidation, which can impact gas exchange. This can lead to fever, cough, shortness of breath, pleuritic pain. The most common pathogen that causes CAP is Streptococcus pneumoniae. And virulence depends on host immunity, comorbidities, and how strong the pathogen is. I wanted to make this a little bit more applicable, so I wanted to look at a case study. So here is Marisa. She's a 36-year-old African-American Hispanic female. She's a university staff member at a local college, and she has a 4-day history of fever, productive cough with colored sputum, yellow. She's got pleuritic chest pain, she's got increasing fatigue, and she was recently exposed to someone who had an upper respiratory infection. Her past medical history includes mild asthma, which she manages with albuterol inhalers. She doesn't smoke, she's never been hospitalized. Her physical exam revealed a right lower lobe with crackles and mild tachypnea, so she's breathing at a higher rate. And her chest x-ray showed right lower lobe consolidation and infiltrates. So as we go forward, looking at risk factors and etiology, CAP occurs when microorganisms overcome the host's normal respiratory defenses. This leads to inflammation of the lungs and sometimes can overtake some of the alveoli, causing atelectasis and things like that, or it could be filled with pus. So as a patient progresses through the pneumonia process, then they start to have increasing respiratory symptoms, low O2, things like that. So what ultimately puts people higher at risk is comorbidity and other issues that might impact their health. So we're looking at advanced age, history of smoking, immunosuppression, whether you're on a medication or a patient has an issue with their health, such as HIV. Also, environmental exposures can put people at higher risk. So some subjective findings. So CAD can be tricky to, or CAP can be tricky to diagnose as it mimics many other upper respiratory infections. So it's really important to do a great history and physical on these patients. Their chief complaints often are cough, fever, and shortness of breath. It can be sudden or gradual. It can be productive or dry. So there's many variables. So you want to make sure that you're really getting a great history. A lot of these patients have decreased appetite, occasional nausea and vomiting, and they could have had a recent history like Marisa did of exposure to someone that's had a viral illness. If you're suspicious of CAP, you're going to look for signs of fever, tachycardia, tachypnea. These patients can have normotensive or hypotensive blood pressures, decreased O2, less than 94% on room air. They may even need oxygen support depending on their comorbidities and health prior. Usually they appear like they're not feeling well. They could be diaphoretic or fatigued. They could have chills. Many are breathing and using accessory muscles. On lung exam, you might see asymmetrical chest expansion if they have a consolidation in one side versus the other. Tactile fremitus can be present, and you can also have egophony and dullness with percussion. Other findings, you're going to be seeing diaphoretic pale skin. Confusion is a number one sign in elderly patients that something is up. Diagnostic studies, you're going to want to do some chest x-rays. You're going to be looking for infiltration or consolidation. You're also going to look at their white count, and you can do that via CBC. Crackles and rails are common when you're listening to breath sounds. As I mentioned, egophony, you're going to hear that E to A change as you're auscultating the lung sounds and lung fields. These patients can even come in wheezing, and so a lot of people mistake this for other differentials. The O2 saturation, if you draw an ABG, it's going to show hypoxia most likely. Sputum culture and gram stain are often helpful to identify which pathogen we're dealing with. So you can treat them empirically, but then once you get that culture back, you can find that helpful as well. Hallmark signs and symptoms of CAP, you're looking at cough, fever and chills, pleuritic chest pain, that tachycardia, tachypnea, so fast heart rate, fast breathing. Rails and crackles are a cardinal sign. You're going to hear bronchial breath sounds. Dullness to percussion. If you're percussing over the lower lung fields, you'll hear that you're not getting that same resonance. Fatigue, malaise, and anorexia. As we mentioned, they have decreased appetites. A lot of times you'll see that in older adults along with confusion. Chest x-ray confirmation showing lobar or patchy infiltrates is the diagnostic hallmark for CAP. So you're going to be definitely ordering that chest x-ray to rule in or rule out these diagnoses. As I mentioned, there are several differentials that CAP can be mistaken for. So acute bronchitis, you're going to see that productive cough, that colored sputum, but it lacks the focal findings of the chest x-ray. That usually is normal with patients with acute bronchitis. Congestive heart failure, if you have those older patients or even young patients with a heart history, you can see people that look a little bit like it mimics CHF exacerbation, but you're not seeing those interstitial infiltrates on chest x-ray. Again, that imaging is key. Pulmonary embolism, this can cause pleuritic chest pain, cough, and dyspnea. This is one of those red flags, do not miss diagnoses that we want to scan for no matter what, but that purulent sputum, that fever are uncommon, and the chest imaging is going to look different. If you're looking at PE, you're going to want to also look at further imaging to really rule that in. There are a couple other differentials. We only needed to include 3, but you'd be assessing for and ruling out an asthma exacerbation, especially in our patient, Marisa, COPD exacerbation, or even COVID. If these patients have a really sore throat, you're also going to be looking at strep. A lot of times patients will come in and they think they have strep throat because their throat is really sore. We do the test and work up, do the cultures and sputums for all of these, and then we find out that they have community-acquired pneumonia instead. For labs and diagnostics, we started to step into this, but as we mentioned, the gold standard for diagnosing is that chest x-ray. For the initial diagnostic workup, we're going to be looking at blood labs. So you're going to look at a BMP, basic metabolic panel. It might show you leukocytosis. You're going to see that in the CBC. You're going to look at renal function in the BMP, excuse me. Pulse ox, you're going to see decreased oxygenation, arterial blood gas if you have a patient that ends up in the hospital or ICU. Blood cultures are great for diagnosing and specifying what exactly is going on. And if you have a patient that goes septic, sputum, gram stain, and culture is what we're going to be doing as general practitioners in a primary care setting. And then you can also test through urinary antigen test and viral PCRs. As far as clinical tools, one of the best tools that I found while I was doing research is Curb 65. This is going to score patients on a criteria and give them points for each criteria that they meet, determining whether they can stay outpatient or they need to be hospitalized. So you're going to look at confusion, urea greater than 19, respiratory rate greater than 30, blood pressure systolic less than 90, or diastolic less than 60, and then an age greater than 65. You're looking, the lower the score, the lower the risk, and so you can keep them outpatient. If they're in the moderate, then you're going to want them observed at a higher level. And high risk patients, you're going to hospitalize, even look at ICU care. So for your specific assessment, to support the findings, we talked a little bit about those things that the patient is reporting in their history, but you're going to be looking at subjective and objective data. You're going to want to look for fever, that productive cough, what color their sputum is, if they're having chest pain, shortness of breath. You're going to be listening to them and seeing if they have crackles or they have bronchial constriction. If they have wheezing, you're going to look at that chest x-ray showing if they have patchy consolidation and infiltrates. You're going to be ruling out through all the different differential diagnoses, and then you're going to be using that curve 65 to determine if you can keep them in a clinic setting or if you're going to want to hospitalize them. For your plan of care, you look at outpatient and inpatient very differently. We're going to treat with antibiotic therapy if they do come back positive for if their white blood count is elevated or their sputum comes back positive. We're going to look at treating them with amoxicillin, doxycycline. They even use Z-Paks, but those have gone out of Zen because of resistance. We're seeing a lot of people are building up a resistance to that azithromycin pack. So as an outpatient, if you have comorbidities, you're going to add that clavulanate to the amoxicillin. So you're going to double down there, or you're going to go for a macrolide or doxycycline, or even a fluoroquinolone like levofloxacin. To treat. If you have to go inpatient, sometimes these patients, especially in the elderly, they're dehydrated, they're not well fed, they have malnutrition. You're trying to beef them up a little bit, and they're going to need IV antibiotics. So you're going to be looking at a different care path here. And they're going to have to be on this. Outpatient, typically you're looking at 7 to 10 days oral therapy. Inpatient, you're looking 5 to 7 days IV therapy. Supportive meds, you can use antipyretics for fever, you can use cough suppressants, you're going to use things that are going to clear out the mucus. So it's more of the comfort therapies. You're going to want rest and gradual return to work and activities. If they're smokers, definitely tell them to cut it out. You're going to want to do a follow-up chest x-ray after you get them stable. You're going to monitor their oxygenation. If they are not doing well, then I would say that you would want to have them observed, maybe have supplemental oxygen for a few days until they clear the infection. Vaccinations, when they are feeling well again, not while they're having acute illness, is recommended. Pneumococcal vaccines are recommended for patients over 50. Education, adherence to antibiotics, symptom monitoring, and when to seek urgent care. You want these patients to be followed well after they do go home. If they're able to stay as an outpatient, they can turn on a dime. So you want to make sure they know when to call back in if they're not seeing improvement. Just a note, this isn't part of what was required, but corticosteroid use in CAP, people that have severe community-acquired pneumonia do often require corticosteroid use, but it is not recommended in certain states. So in severe CAP for outpatient, it's usually used if you're inpatient and you're seeing underlying issues, comorbidities, or exacerbations of asthma. You're not going to see it if you have patients with uncontrolled diabetes, active GI bleeding, or immunosuppression. And there is a lot of different data to support staying away from corticosteroids with community-acquired pneumonia if you can, and if you can just see a patient, match them where they are with outpatient therapy. Back to our patient Marisa. So our Marisa, we did actually see that she had community-acquired pneumonia. She was ruled in, so she received amoxicillin 1 gram PO every 8 hours for 7 days. She was encouraged to complete a round of the antibiotics, complete all antibiotics, don't skip any doses. We wanted her to stay hydrated. We asked her to stay home from work for a few days to rest. And then we did give her those red flags to call back in if things weren't progressing and she needed to be seen. She was encouraged to continue the use of her inhaler for her asthma. She felt better after 4 days, went back to work. She continued and she completed her antibiotics. And at day 10, she felt like she was herself again, continued her albuterol outpatient. We did ask her to come back in for a 6 week follow up for her chest x ray, and everything was clear. So, this is my presentation for community acquired pneumonia. I hope you enjoyed it. I hope you learned something. And I thank you for taking the time to listen today. If you guys are interested in any of the references that I used for this project, you can find them here at the end of this PowerPoint, or I will try to link them below. Thanks again.